Good morning, everybody. Welcome to our very first newborn screening all-team meeting for 2020. Somehow it's 2020 already. We're going to start off today with a special guest. I'd like to introduce to you Dr. Katherine Mathews. She is the director of the Neuromuscular Clinic here in the Stead Family Department of Pediatrics. And she is also designated as our MD medical consultant for spinal muscular atrophy. And she's going to talk to us today and teach us about SMA. Dr. Mathews.
Okay, is that good? So I'm just going to give an overview of spinal muscular atrophy today. Spinal muscular atrophy is an inherited disorder typically presenting in infancy or childhood resulting in progressive weakness. So that's just the overview. What I'm going to talk about now is the clinical features of SMA, some basic physiology and genetics, how we approach the diagnosis of a child suspected of having SMA, management, and then I'll touch on newborn screening, which is what you're here for today. This is a not to be read slide, but I just wanted to make a point that spinal muscular atrophy does not refer to one disease, but a whole bunch of different genetic diseases. I am only going to be discussing one type of spinal muscular atrophy, the 5q linked spinal muscular atrophy, and that is the only type we will be looking for in newborn screening. So you can ignore the rest of this except to know that we're not talking about any of those other diseases. So 5q linked spinal muscular atrophy. It is a disease that comprises a clinical spectrum, and I'm going to be saying this like 4 or 5 times. So the key symptoms are weakness and muscle atrophy, but it's one disease in a continuum of severity. So historically, we've referred to this continuum of severity as different diseases, but we now know it is one, and there isn't a hard line between different types. We refer to different types based on the best motor milestones achieved. So, and you'll see a little bit of difference in my slides as definitions. Everybody doesn't have exactly the same definitions, but in general, type 0 is prenatal onset. Type 1 children never achieve the ability to sit. Type 2 children sit but don't achieve the ability to walk. Type 3 children at their best were able to walk at some point. Now, because it is a continuum, in order to facilitate communication, some people have also subdivided the types further. So you can talk about type, and there are different types of subtypes, so there isn't just one agreed upon approach to these minor subtypes, but this is one example that's not uncommonly used. So type 1A are the more severe type 1s. They present in the first 2 weeks of life with weakness. 1B is sort of typical, and 1C able to achieve some head control and can almost sit. So they're almost type 2s, but not quite type 2s. And then the type 3s can also be divided into different severities based on when their age of onset of motor symptoms. So the importance of that is not to remember all these different subtypes, but to know that there is a continuum of severity. So when you say you've got type 1 SMA, you're not just describing one phenotype. There is a range. So type 1 SMA is the original eponym for it was Wernicke-Hoffmann disease, and this is the most common type. It is about 60% of children with spinal muscular atrophy will have type 1. Presents with hypotonia and proximal weakness, and by the way, all the patient photos in this are taken off the web. They are not our patients. The children may be able to just move distal limbs. They have weak muscles of respiration. They'll often have this bell-shaped chest, a very narrow, then this child shows that very narrow chest, and then abdominal breathing. They breathe using their diaphragm, not their intercostals. They often will develop malnutrition. This child has an NG tube, you can see. They have difficulty swallowing, and historically these children, 100% are dead by age 2 without aggressive intervention. Type 2, these are the kids who achieve sitting but don't achieve walking. This is maybe roughly 30%. They typically have onset before 18 months. The weakness is often worst in the legs, and they can't walk because that's definitional. They will often develop things like scoliosis and difficulty with breathing later on. The lifespan for this group of children is highly variable. And then types 3 and 4. Type 3 was historically called Kugelberg-Vielander disease. This was onset, and there's some variability depending on what you read about the onset, but somewhere between 18 months and 21 years. After 21 years, then it is often called type 4 with onset in adulthood. So typically these children will present with weakness around between 5 and 15. They are able to walk, obviously, if they present by age 5. And proximal muscles are often affected first. These children have a very slowly progressive course, although most will require a wheelchair at some point, often sometime into adulthood. And these later types can often be confused with other neuromuscular diseases. So typical physical findings, and the physical findings will depend a little bit on when the child presents, but weakness is the core physical finding that progresses over time, can involve all muscles except for the muscles of extraocular movements. Tongue fasciculations are if you're a medical student, tongue fasciculations are your board exam SMA association. Tongue fasciculations in a newborn or in a young infant are actually very difficult to be confident on. If you are not familiar with tongue fasciculations, there are lots and lots of images out there on Google video images, so I didn't put any up here, but if you want to see some, they're all out there. They are very useful. They're very obvious latent disease. They are difficult to call with confidence in an infant. These children have normal sensory exams, and they typically have absent or difficult to elicit deep tendon reflexes, although that is not true in the later onset forms. Tremor is a common feature, particularly of type 2, and these children classically have normal intellectual function. They have the same distribution of intellectual function as the general population. In other words, the brain is not typically affected. And all of these features have other causes. So while we give this list of things and it sounds like, oh, this must be very easy, it's obviously SMA, it's never obviously SMA. There's always a differential diagnosis. So given that there is always a differential diagnosis, what is the pathophysiology? And then we'll go on to how we use that to make the diagnosis. So this is the motor system. So if a child presents with weakness, they have a problem somewhere in the motor system, somewhere between the brain and the muscle. Brain, anterior horn cell or motor neuron, peripheral nerve, neuromuscular junction, or muscle. And the lower motor neuron, or the lower motor neuron system, the neuromuscular disorders are the ones that are in the box here. And those are the ones that we typically think of when we have a differential for a child who has SMA. In spinal muscular atrophy, what you have is a progressive loss of the motor neurons. So this is where the problem is in spinal muscular atrophy. It's in the spinal cord, and there are a series of motor neurons that extend up and down the spinal cord, and those are lost. So looked at in a little bit different way, here's the spinal cord. This is where the motor neurons are. Each motor neuron sends out a process, which is the peripheral nerve, that communicates with a series of muscle fibers. If you lose those motor neurons, you don't have any way for the message from the brain to get to these muscle fibers. Now, if you lose one or two of those motor neurons, but there are still others out there, you can see that each motor neuron talks to several different muscle fibers. So if I lose one of those, the remaining motor neurons can send sprouts and try to talk to more different muscle fibers. So when we do a muscle biopsy, we can see evidence of that. So we have lots of little teeny tiny muscle fibers that have lost their message from the anterior horn cell or the motor neuron. And then we have great big clusters of muscle fibers where one motor neuron is now talking to a lot of them, and those muscle fibers are trying to do the work of the entire muscle. So why are those motor neurons lost? They're lost because they have a deficiency of the protein called survival motor neuron. And you lose the survival motor neuron protein if you have mutations in the survival motor neuron gene called SMN1. It's located on 5q. This is what we started out with, again telling you that I'm only talking about the 5q linked SMAs. And this is an autosomal recessive disease, so you have to have a mutation on both the SMN1 copy from your mother and from your father. Carriers are asymptomatic, so if you have 50% of the amount of SMN that you need to keep your anterior horn cells healthy, you're totally normal. So the genetics is a little bit more complex. So this is SMN1, and then proximal to SMN1 there is a very closely related gene called SMN2. SMN2 has a single point mutation that results in exclusion of exon 7 from the SMN2 transcript. So this is the visual that I prefer for it. So this is the SMN1 gene. If you have SMN1, you make a full-length SMN RNA and a robust SMN protein, and your motor neurons or anterior horn cells are happy and live, and you're strong. SMN2 has this point mutation, and because of read-through and, we aren't perfect in how we view these little mutations, you make a teeny tiny bit of SMN protein from the SMN2 gene, even though it has this defect, this mutation. But most, at least 90% of what is made from SMN2 is lacking that exon 7, and so what you get is a truncated mRNA, and the protein it's tied out or chewed up and spit out, and you don't get any functional protein. So if you lack SMN1, you only make a little teeny tiny bit of SMN protein, and you lose anterior horn cells. Now, it makes sense then that if you make, maybe 10% of a full-length SMN protein from every copy of SMN2, we all have a variable number of copies of SMN2. So some of us in this room might have no copies of SMN2. Some of us might have 5 copies of SMN2. It doesn't make any difference because everybody in this room, looking around, I don't see anybody with SMA. Everybody in this room has 2 copies of SMN1. So, but your SMN2 copy is going to be a major determinant of which of those phenotypes of SMA you have. So the more SMN protein you make, the milder your disease. So this is a review of 625 cases. So this is SMA type 1. These are the children who don't sit. And this is the copy number. So you can see in red that the vast majority of children with SMA type 1 will have 2 copies of SMN2, but a few will have 3 copies and a few will have 1 copy. If you look at SMA type 2, the ones who sit but don't walk, the vast majority have the green number here, which is 3 copies of SMN2, but some will have 2 copies. And if we go into the milder form, SMA3, those who walk but but develop progressive weakness, many of them have 3 copies. Some have 4 copies. A few have 2 copies, so it gets a lot more confusing down here. And if we look at this now in reverse, which is important for newborn screening, because this diagram is we know what the patient has. This diagram is, if we say you've got X number of SMN2 copies, what is your phenotype? So here, if you have 1 SMN2 copy, you are going to, with a very high degree of probability, have a severe disease, type 1 or type 0. And again, this is, I didn't point this out, this is almost 3,500 cases. Now, this is from the literature and from one center, so there may be some variation in typing, but you get the idea that the vast majority of those with 1 copy of SMN2 are going to have severe disease. 2 copies of SMN2, again, you are highly likely to have type 1 or maybe type 2, rarely type 3 SMA. 3 copies of SMN2, pretty likely to have type 2 SMA, maybe type 3, maybe type 1. And once you get to 4 or more copies, you're much more likely to have a milder form of SMA. And this will become important when I talk about the consensus approach to treatment of children identified through newborn screening. So you might sort of keep this in mind. So when we think about the determinants of phenotype, so one study, there's a patient-reported database, a very large database, and they looked at concordance between siblings. So if one child has SMN1, what is the probability that the second child has SMN1 also? And they found about 85% of siblings in this patient self-reported database were concordant for the phenotype. They both siblings, or all 3 siblings, had either type 1, 2, or 3. So it suggests that, as we would have predicted, there's a very strong genetic contribution to the phenotype. And as I just told you, the SMN2 copy number is a primary determinant, but most of those siblings are going to have, if they are full biological siblings, are going to have the same copy number. So what other explanations are there? Well, one thing is that we know that there are rare genetic variants that can also modify the phenotype, and one of the ones that's coolest in my mind is a genetic variant that spontaneously promotes the inclusion of exon 7 in the SMN2 gene. So it's sort of like a mutation that creates the therapy. So then you get exon 7 inclusion, and you're going to have a lot more functional protein coming from SMN2, even though you have the original mutation. So there are some other variants that have been identified that can modify the phenotype. And then non-genetic factors can modify the phenotype. If you have a severe hypoxic ischemic injury or some other medical problems, those can can impact your phenotype. So diagnostic testing. The mainstay of diagnostic testing is genetic testing for deletion in the SMN1 gene. So this is how you make the diagnosis. You don't do anything else. This is how you make the diagnosis. So 95% of children or adults with SMA across types will have deletion of at least exon 7 and 8, or at least exon 7 in the SMN1 gene. It can be larger deletion than that, but what we test for is deletion of exon 7 and 8 or exon 7 in the SMN1 gene. This will be diagnostic in 95% of the cases, and these are the cases that we will detect with newborn screening. Now, about 5% of patients will have on one copy of their SMN gene will have a deletion. The other copy will have a point mutation. We will not detect those with newborn screening. So if you have a very strong suspicion, you have a child with you in clinic who is very weak, and you strongly suspect spinal muscular atrophy, what you need to do is look for carrier testing. Do they have one deleted copy? And then you do sequencing to see if they have a point mutation in the second copy. And those, as I said, will be missed with newborn screening. So these are supportive tests. You can do EMG or you can do a muscle biopsy as supportive tests. So these are done if you have the child in clinic who you think has SMA, you can't come up with another explanation, your genetic testing is not diagnostic, and you need further support for your diagnosis. So EMG will show evidence of denervation, which is just lack of anterior horn cell talking to the muscle fiber, but it's nonspecific. A muscle biopsy, and again, this shows the same thing that I showed you before, clusters of small fibers and clusters of big fibers, is supportive but not diagnostic. So the only test that is diagnostic is our genetic testing. So management. So first of all, there is non-genetic management, and this remains, I'm going to be talking about other kinds of management, but non-genetic management is the core of what we do for patients, and until about 2 years ago, this is all we could do for patients. So the non-genetic or non-specific management consists of family education, genetic counseling. As I said, this is an autosomal recessive disorder, so there is a 25% chance with future pregnancies that this couple will have another child with spinal muscular atrophy. There then is multidisciplinary supportive care. A key element of that is respiratory. So these children, prior to any treatment or without any treatment, type 1 children will die of respiratory failure. So we want to evaluate their respiratory function, and then we can discuss with the family the options of invasive versus non-invasive ventilation. So in other words, a tracheostomy versus doing BiPAP. How much BiPAP do they need it? Do they need it only at night? Do they need it during the day? We also will do cough assist to help them clear the airways and keep the lungs healthy. So pulmonary care is a key element of the ongoing support. The other service that is a major element of the ongoing support for children with spinal muscular atrophy is GI and dietary. So the very severely affected babies often are not able to feed adequately to support growth. They can also have reflux, which can also exacerbate their pulmonary symptoms. So careful attention to nutrition. Some of the milder children can actually have problems with becoming overweight. They aren't able to exercise. They're in a wheelchair. That can also impact their overall health care. So you need to pay close attention to dietary and GI problems. These children are at risk for scoliosis, contractures, osteoporosis, so we do routine management and monitoring for those. We need to provide support for mobility. The vast majority of these children and teenagers will require a wheelchair and other sort of durable medical equipment, and then palliative care as needed. So in December 23rd, 2016, everybody with SMA and everybody who cares for those with SMA's lives changed dramatically because the FDA approved Spinraza, which is the trade name. Nusinersen is the generic name for treatment of spinal muscular atrophy. Nusinersen is administered via lumbar puncture. It's dosed as three doses given every 2 weeks, then another dose in 4 weeks, and then it's every 4 months for life. And the FDA approved it without limitations on who could be treated. The mechanism of action of nusinersen is kind of like that spontaneous mutation I told you about before, only we're doing it to them. So here is the SMN1 gene, and in a normal situation, the SMN1 gene makes a full-length SMN protein, and the SMN2 gene makes a short RNA that is lacking exon 7. In the case of SMA, you don't make any SMN1, and with nusinersen, what we're doing is we're putting an antisense oligonucleotide here that will result in inclusion of exon 7. And so with the antisense nucleotide, you make a full-length mRNA from the SMN2 gene. So it's just like that spontaneous mutation I mentioned. So the concept is that this will, while it will not result in creating new anterior horn cells that are gone, those anterior horn cells that are teetering on the edge and just about to die because they don't have any of that survival motor neuron protein now can get survival motor neuron protein and hopefully come back to be refreshed. And the ones that are completely healthy will stay healthy. So does it work? So the FDA approval was based on interim analysis, and what I'm going to show you is the publication from the final placebo-controlled phase 3 trial using nusinersen in infantile onset SMA. So there were 121 subjects who were in the final analysis. All of these patients had 2 copies of SMN2, so all of them were in the type 2 or type 3, if you think back to those earlier diagrams. They all had to be less than 6 months old at the time of onset of symptoms and less than 7 months old at trial enrollment. And they were divided 2-to-1, so 80 received nusinersen and 41 were controls who had a sham. They just pricked the back of the spine with a needle and put a Band-Aid on it and called that a lumbar puncture. So this was truly a sham-controlled trial. The efficacy and endpoints were assessed up to 394 days. Nusinersen was generally very well tolerated. They were able to get spinal cord pathology on one child who died after receiving nusinersen, and were able to demonstrate that there was a significant increase in SMN protein, which is what you would predict with the mechanism of action of the drug. And here are the results. So the top graph here is event-free survival. So for all these outcome measures, their event-free survival is survival without long-term ventilation, or survival without death. So many families will decide to do long-term either tracheostomy and ventilator, or long-term and many hours per day of BiPAP support. So those children won't die a respiratory death, so that is an event, the need for respiratory support. So you can see that, so first of all, and I didn't put the graph up here, these children in the natural history studies, children with spinal muscular atrophy do not improve, they do not gain new motor milestones, so they lose motor milestones. You don't gain motor milestones. So 51% of the group that was treated in this study gained motor milestones, which is unheard of in the natural history, whereas, and in the control group. So 0 infants in the control group gained motor milestones. And then when you look at the death or permanent ventilation, which is what I have over here, 39% of the nusinersen group met the endpoint of either death or permanent ventilation, and 68% of the control group. The overall survival is shown down here, and again, it strongly favors nusinersen over the control group. So the risk of death or permanent ventilation was 47% lower in the nusinersen group, odds ratio, or hazard ratio, I mean, of 0.53. So the placebo-controlled long-term 1-year follow-up was compellingly in favor of nusinersen, and children are surviving with a disease that was uniformly fatal. And the real-world experience has supported that. So these were all children, this trial is all children who were symptomatic and were diagnosed because they became symptomatic. They had to have symptoms before age 6 months in order to be enrolled. So if you think about the mechanism of disease, it makes sense that you would like to save those anterior horn cells before they are lost, or those motor neurons before they're lost. So this is a study of pre-symptomatic treatment with nusinersen or Spinraza. This is in infants who had 2 or 3 SMN1 copies, only 25 infants here. Mean age at dosing was 22 days, whereas the other one, it was more like between 3 and 4 months. The mean age at analysis was 34.8 months. And this is the results for the entire group, the black line. The green line is for those with SMN. This is event-free survival, so again, either long-term ventilation or death. The infants with 3 copies of SMN2 had no events. The infants with 2 copies had some events, but if you then compare this mentally with the previous slides, earlier treatment is better. The earlier treatment is more effective. You want to start treatment before those anterior horn cells or motor neurons are lost. So that was all very good, and we were all spending most of our lives delivering Spinraza or nusinersen to children via lumbar puncture. And then in December 2019, the FDA approved gene replacement therapy for spinal muscular atrophy. So there is some restriction on this. It was approved for children under age 2. And the gene replacement therapy is a one-time IV infusion. The approved drug uses an AAV9 virus, an inactivated virus that crosses the blood-brain barrier, and it has a strong continuous promoter. It creates a little mini gene. It doesn't integrate into the normal human genome. It creates a little mini gene that sits outside of the normal human genome. But with this strong promoter, the concept is that you'll have these little mini genes that are sitting inside the cells, and they are going to continuously produce SMN1 protein with a single infusion. So I actually practice this. This trade name is really, or this generic name is really terrible. So I'm going to call it, I'm just going to use the trade name because it's terrible. So, but there it is. Go for it. So we do not have the same kind of phase 3 study result that we had for nusinersen. So what I'm giving you here is an interim sort of report, but it's what is published. And so this you can't do, I wanted to make it clear that you can't do a head-to-head comparison between what I showed you for nusinersen and what I'm showing you here for Zolgensma. So this is a phase 1-2 study result. This is very preliminary. It's what's published. It's gene replacement for type 1 infants. There are only 12 infants in this study. But this, again, is the data on which the FDA gave the approval. All had 2 copies, like the nusinersen result. 3 got a low dose of virus, and 9 got a high dose of virus. The 3 with a low dose were also treated later. The 9 with the high dose were treated at an earlier age on average. And what I'm showing here is motor function. So these graphs were the most easy to interpret from this paper. So the low dose patients who were treated later, there is some improvement. This is the level at which no infant achieved this motor milestone in a natural history study. So this 40 never happens in natural history. The children who were treated with Zolgensma at low dose got better. They made improvements in this motor outcome score, but they didn't get up into a very high number. In contrast, the children who were treated with the high dose, you can see that they achieved motor milestones far above what the natural history ever does. The child who was treated the latest did not have as dramatic an outcome. This is a child treated at 6 or 7 months. And again, you get a sense that the earlier the child is treated, the better the outcomes. This is the ceiling for the study. So like nusinersen, we are seeing improvement in motor outcomes, which you do not see in untreated children with spinal muscular atrophy. And this is a study taking those results with those 12 children and comparing them the results at 24 months, comparing them to both natural history study and to healthy controls. And this is the natural history study. This is event-free survival, which is either permanent ventilation or death. The natural history study, again, is that virtually 100% will have had the event by age 24 months, whereas none of the patients in this very small study who were treated with the gene replacement at high dose had the event. So again, very promising results. There were safety considerations, and this is now, since it's been FDA approved and there are ongoing studies, there are lots of safety reports out there. You can't use this drug if you have pre-existing antibodies to the virus. There's potential for liver toxicity, so we put people on steroids at the time that they get the virus to reduce any inflammation in response to the virus for at least a month, and then taper. You can't use this drug if there's any pre-existing liver disease, and you can't use if there's pre-existing heart disease. These are not the only possibilities. There are other treatment options on the horizon. The one that is probably closest to being on the horizon, and we don't know yet whether it's going to be approved, but is risdiplam. It's a small molecule splicing modulator, so again, similar mechanism of action to nusinersen. It's taken orally, which is really causing great excitement since many of these patients have scoliosis and things. If we are trying to do exon skipping or exon inclusion, doing lumbar punctures is often challenging. In patients and healthy volunteers and animals, we've been able to show that it does increase the SMN transcript. And results have not yet been published, but there was a statistically significant improvement from baseline after 1 year of treatment in these older children. So we're talking about a milder group than the patients that we talked about before in results presented at meetings. It's been safe and well tolerated, and we expect a decision by May 24th, 2020. So this is on the horizon, and other options are on the horizon. So SMA monitoring. Monitoring is a huge part of what we do in the management of SMA with treatment. So there are formal physical therapy assessments that are required before treatment and then to monitor response. And then depending on the drug, there's regular blood and or urine monitoring that's required. I mentioned this earlier, but in general, these treatments are not curative. So all that general ongoing neuromuscular care and pulmonary care is still critical. You don't just give the treatment, you don't give the gene replacement and then say, bye, send me a graduation card from high school. You still follow the patients. You still need to ensure that they are getting their ongoing neuromuscular care. Epidemiology and newborn screening. So spinal muscular atrophy is the second most common hereditary neuromuscular disease after Duchenne muscular dystrophy. Genetic diagnosis in 1 to 7,000 to 1 to 10,000 live births. Carrier rate in Caucasians, 1 in 40 to 1 in 60. This is pretty darn common. I think that I am correct that this number, which I just got out of the Des Moines Register, was from 2018, but I wrote it down and then I forgot to write down for sure the year. But I think it's the 2018, 37,672 births in Iowa. So if we go by that, how many SMAs per live births, do the calculation, something between 4 and 6 children should be born annually in Iowa with spinal muscular atrophy, and roughly 90% of these are predicted to have types 1 or type 2. So if we start newborn screening, we're expecting to see somewhere between 4 and 6 kids annually. So newborn screening, there are a lot of techniques for doing screening that have been tested, and the one that has sort of risen to the top is a PCR-based assay that can be combined with severe combined immunodeficiency disease. SMA was added to the recommended list of diseases for screening at a national level, so recommended and approved at the national level in 2018, and we are here because we have now voted on going forward with adding it in Iowa, and it's going to be combined with SCID, which is already currently on our newborn screening panel. So our panel, I already mentioned, is going to be multiplex PCR assay combined with SCID. We will detect the homozygous deletion of exon 7 of SMN1. We will miss the 5% who have a point mutation on one allele. We will expect very few false positives. We will not be reporting carrier status. And if you have what appears to be a homozygous deletion of exon 7, the Iowa newborn screening staff will notify the primary care provider. The primary care provider notifies the family and refers the child to the pediatric neuromuscular program. We will then get the patient in as soon as is humanly possible and do an exam and then confirmatory genetic testing and further education with the family. The family will be notified of the results of the confirmatory testing by the neuromuscular program, and we will get them in expeditiously to talk about what the treatment options are at that time and what they would like to proceed with, if anything. So I just thought I would go through, this is probably the largest study that is published and most recently that is similar to what we are going to be doing. So the Australia experience, they've screened over 100,000 infants. They had 10 screen positive. One was a false positive, and the patient was truly a carrier. So of the 9 who were confirmed to be SMN, 6 of the 9 had 2 SMN2 copies, so highly likely to be type 1, slightly likely to be type 2, and the remaining 3 had 3 copies, so all of them were in the type 2 to 3 SMA. 44% showed clinical signs of SMA within the first month of life, and those clinical signs were primarily, the initial signs were loss of head and neck strength and loss of tone. They did not see as an initial sign loss of reflexes. They did not see fasciculations or limb weakness. So the first things were head control and low tone. So this one was the one this part was the part I spent a lot of time on. So what was the time course? What could they make work in Australia? So the median time from first blood spot collection to the availability of diagnostic results, so the time that the family, from the blood spot to the time the family got their confirmatory testing, was 13.5 days. That's impressive.
So that's not age.
No.
That's not day of life.
No, that's not day of life 13. It's from the time that the blood spot hit the lab to the time the family got their result was 13.5 days with a range of 8 to 21 days. So they were referred to a specialist by 10 days of life. They were seen by the specialist within 1 to 5 days. The diagnostic, and I didn't add these up to see how this all fit, but the diagnostic blood collected by 12.5 days, and they were available by 18.5 days of life. So the bullet points are age, the 13.5 is the time frame. So they were, all of their newborn screening patients had their diagnostic test results by 24 days of life. So that's impressive, and I think we'll certainly try to match that. And they were able to then have therapeutic planning and intervention started by 26 days of life. So what do we do if you have a patient, we know what we do about treatment if you've got a symptomatic patient. What do we do if we have a pre-symptomatic patient? So there's a consensus statement published, and I've summarized the flow diagram here. If you have 1 copy of SMN2, the patient may be too ill to benefit. So if you have 1 copy of SMN2, they likely were symptomatic in utero. They often are extremely weak with contractures and often other organ system involvement, and so it's really a matter of discussion with the family. It is not totally clear that children with this severity of disease benefit from any of our current treatments. If those anterior horn cells are gone, we can't make them come back, so it's not. Again, if the anterior horn cell is gone, you can't make new anterior horn cells develop by doing gene therapy. You can preserve the current cells.
Not all the neurons can take place.
So with what we know right now, you don't grow new anterior horn cells postnatally. So if one copy of SMN2, a discussion with the family. 2 to 3 copies, you treat as soon as possible. Greater than 3 copies, those children may not be affected yet. And so this consensus statement, I will say, was published prior to the available of Zolgensma, the gene therapy drug. So whether the consensus at the time of treatment, or the consensus statement, the agreement was that you don't do serial lumbar punctures on somebody who may not develop disease for another 10, 15 years. With the Zolgensma available, I think we probably have some discussions here. But for nusinersen, the recommendation was regular follow-up by a neuromuscular specialist every 3 to 6 months initially, with exams, formal testing, standardized measures of motor function and electrophysiology, educate parents about signs and symptoms, and initiate treatment at the earliest sign. So again, earlier treatment, better outcomes, and that's the reason for newborn screening. So up here is contact information for the neuromuscular team, newborn screening program, the laboratory, and administrative questions can go to Kim Piper. So thank you very much for your attention.